I hope you guys are doing well. All right, today we're going to talk about compression. That is chapter 21. And here is our outline for today. First, the effects of external compression. So it improves the venous and lymphatic circulation, limits the shape and size of the tissue, and increases the tissue temperature. We're going to go into each of those. So with the lymphatic circulation, the increased external or hydrostatic pressure increases the amount of fluid that is reabsorbed into the lymphatic system and flushed through the body versus just sitting in the tissues. The intermittent compression may be more effective than static because it milks fluid from proximal to distal vessels. Okay, so with the lymphatic system, the thought is it's kind of like a traffic jam. So, usually with massage and with other things, we are always taking fluid from distal and pushing it more proximal. The thought is it's like a traffic jam that already is blocked up proximally. So if you send more fluid to an area that's already overloaded with fluid, it actually sends the system into more failure versus increasing its ability to handle that fluid. And so what the thought is, you clear the proximal vessels and then push that fluid back and then go more and more distally to allow room for that fluid distally to push proximally. So the traffic example is if the interstate was completely shut down, it was completely stopped, and all the side roads leading to the interstate started getting traffic backed up, you would not then push more cars on the side road and try and clear that out, pushing them all towards an interstate that's already blocked because they're not going to have anywhere to go. But if you first clear off that interstate, you open lanes back up and allow more traffic on the interstate, then you can start clearing the side roads as you go. So the interstate is the proximal areas. Most of the lymph vessels are around, are more proximally like around joints, and especially the neck and the armpits and the groin. And so if you clear those vessels first, it allows room for more fluid from the limbs to be pushed more proximally. So the fluid you still want to go from distal to proximal, but you got to clear the proximal vessels to allow the fluid a place to go and flow more easily. All right, so another thing that compression does is limits the shape and size of tissues. So this is one reason that compression garments are used after an amputation or after burns to help shape the area and help the tissues be pliable and not be hypertrophic. With the increased tissue temperature, the compression garments themselves typically increase the temperature of those areas, which can increase collagenase, which is temperature sensitive, to help break down excessive collagen and keep you from developing those hypertrophic or keloid scars. So it could help decrease the scar formation. What are some of the causes of edema? So it could be an imbalance between hydrostatic pressure and osmotic pressure, which we'll talk about more in the next slide, which is inside and outside of the blood vessels or the lymphatic vessels. It could be because venous or lymphatic vessels are obstructed or they're not working accurately, they're insufficient, not able to keep up with the demand. It could be caused by increased capillary permeability. So there's more fluid staying in the tissues and being pushed out of the blood vessels, but not reabsorbed. Immobility can cause it because the muscle pump, especially in your legs, but other places as well, helps push the fluid back to the heart and in through the circulation. Pregnancy helps or causes edema. It often causes edema. And then certain systemic diseases can cause edema, and those you typically don't treat with compression. So the picture towards the center of the page is a picture of someone with lymphedema, which we do use compression and pressure garments on. The other person on the left side of the page has elephantitis, which often is caused by a bug or an infection, a parasite usually that blocks the lymphatic system, and so we would not treat that typically with compression. So osmotic and hydrostatic pressure. So hydrostatic pressure pushes fluid out of the vessels. Oncotic pressure pushes fluid into the vessels. So the fluid and proteins that are flowing out of the vessels are pushed through hydrostatic pressure, but they are called lymph. Once it's outside of the vessels, that is called lymph. That fluid and the proteins outside of the vessels is lymph. Hydrostatic pressure is typically greater than oncotic pressure, so it pushes fluid out of the vessels, and then that fluid can be reabsorbed by the lymphatic vessels. So if this system is haywire, it could cause more edema, just depending on what's going on with this system. All right, with lymphedema, the lymphatic vessels take that lymph, that fluid, and they remove the bacteria, they filter it and remove foreign particles from it, and then some of the lymph is reabsorbed into circulation. Some of the lymph is filtered by the kidneys and eliminated. With lymphedema, that lymphatic circulation decreases and causes edema. So things that affect the lymphatic circulation and could cause lymphedema are decreased levels of plasma protein, especially albumin, mechanical obstruction of the lymphatic vessels, abnormal distribution of lymphatic vessels or lymph nodes, especially if they are removed. So with some cancers, they will remove the lymph nodes so that the cancer does not become metastatic and doesn't move and spread to other parts of the body. But once those lymph nodes are removed, then automatically there's going to be less lymph drainage in that area and are more likely to have lymphedema in that area because the system cannot keep up because part of the system has been removed. Decreased activity or exercise can also cause lymph fluid to build up, since the muscle pumps are responsible for increasing the venous return and the return of the fluid through the lymphatic system. If a patient has venous insufficiency, what is causing that? So with a healthy blood vessel, when the muscles contract, they open the valves in the veins and push the blood flow up back towards the heart. When the muscles relax, the valves close so that the fluid cannot backflow and cause swelling. With unhealthy vessels, either they have been stretched out or the valves have been damaged for whatever reason, then the muscle pump can still push fluid forward, but when you relax, the fluid backflows and causes a buildup in the tissues and causes edema. Compression can reduce edema by increasing extravascular hydrostatic pressure so that the pressure outside of the vessels is more than inside the vessels, which would cause a little bit more fluid to be reabsorbed. It can promote circulation and it can move fluid proximally through the vessels, so back towards the heart. This is an example of a venous stasis ulcer. So it's an area of tissue breakdown and necrosis, which is dead tissue due to impaired venous circulation. Usually it's a large flat ulcer. It's on the distal portion of the legs more so than anywhere else. And it's typically associated with edema. So there's swelling in the area that is just pooling in the area and breaking down the tissue and causing sores. For a venous stasis ulcer, compression will improve the venous circulation. It can improve the rate of healing for the ulcers by decreasing the amount of blood that's pooling in the area. Remember, we've talked about it in class, but when blood, any blood, nutrients, whatever, typically likes to go from a higher gradient to a lower gradient. So if there's a bunch of people in a room and a door opens, people are going to start leaving the room because they don't want to be packed in. So same thing with the fluid and the nutrients. If there is an area where there is swelling, less nutrients and fluid, blood flow goes to that area because it's already packed. It doesn't really have room. It's already at a higher pressure, and fluid and nutrients like to go to a lower pressure. So when you have edema in an area, although there's blood sitting in that area, it's not healthy blood. It's not good, nutrient-rich, oxygen-rich blood that's keeping the tissues healthy. It's just old blood that has the toxins in it. It has carbon dioxide. It has features that are typically pushed and filtered out through venous return and through the lymph that are just staying in the area and causing it to be unhealthy. So when we improve circulation and we push some of the swelling out, we also allow for new blood with nutrients and oxygen to come in and be delivered to keep the tissue healthy and to create healing. Multi-layer compression is more effective than single layer. Compression therapy is one of the cornerstones of venous ulcer treatment. It's one of the main things used to treat venous ulcers. When we are preventing DVT, that's a deep vein thrombosis or a blood clot, when we're trying to keep one from developing specifically in the legs, typically, then we want to improve that local circulation. So when circulation is decreased, you are more likely to get a DVT, which is why on a plane, they tell pregnant women to pump their ankles to increase that muscle pump and that venous return so that the blood doesn't just sit and pool in the area, because that's when blood clots typically form. After a surgery, when you're laying in bed a lot, you also need to either do some ankle pumps or maybe use one of these pneumonic pressure devices, pressure pumps that squeezes the area for you to increase venous return and keep the blood from pooling in the area. So compression can increase that circulation and reduce your risk of a DVT. It's most effective when it's combined with other forms of prophylaxis like blood thinners, active movement, getting the patient up, walking them around, things like that. With residual limb shaping after an amputation, so the residual limb needs to be shaped in order to be functional so that they can weight bear with a prosthetic device and it can fit evenly and not create sores or increased areas of pressure. Usually static and intermittent compression are used. The intermittent compression can reduce the residual limb size in about half the time of other techniques. Typically, patients are sent home with some type of pressure garment or sleeve that they wear that puts even pressure along the whole residual limb to help decrease the swelling and shape it in a good way that will fit well in a prosthetic device. Compression can also help control hypertrophic scarring. So this type of scarring is common in people who have had burns or with complications after surgeries or things like that. Those types of scars are typically not pliable. They don't move very well. They're rigid and don't move like the tissue that they've replaced. They typically are raised and more hypertrophic, more like the keloid scar. And it's recommended to do 20 to 30 millimeters of mercury for 23 hours a day to reduce hypertrophic scarring. So a pressure sleeve, a compression sleeve would be key. That's really only removed for showering so that you are able to really improve the scarring. The sleeve also acts as a mold for new tissue growth, so it grows evenly and doesn't just combine and multiply in one place to create that scar. Here are the contraindications for compression therapy. So, for intermittent or sequential pressure compression pumps, like we use in the hospitals after a surgery, you do not use those with somebody who has heart failure or pulmonary edema if their heart is already overloaded with too much fluid, or they have swelling in their lungs and they cannot breathe well. If you push more fluid back to their heart and lungs, they are going to decline. Their condition's going to decline. It's dangerous for them. If they have a DVT or pulmonary embolism, so blood clots, you do not want to do it because you could send the DVT somewhere else and create more damage to another structure. Obstructed lymphatic or venous return, if there's no way for it to go, then we don't want to be pushing it back, making the symptoms worse. Severe PAD, that's peripheral artery disease. Acute local skin infection, significant hypoproteinemia, so increase or low protein amounts in the blood, then you would not use it. If they have an acute trauma or a fracture in the area, of course, you don't want anything over that area squeezing. And then arterial revascularization, you don't want to damage little blood vessels that are just forming after some damage. Some of the precautions are impaired sensation or mentation, uncontrolled high blood pressure, cancer, stroke, or significant cerebrovascular insufficiency, not getting enough blood to the brain, or over a superficial peripheral nerve. Sometimes that can be or a precaution. It may not be safe. If it's just pushing on that nerve, it could create nerve damage. Some of the adverse effects, so it could aggravate the condition that's causing the edema, especially if, let's say with lymphedema, you don't clear out those proximal blood vessels or those proximal lymph nodes really to allow space for more flow, and you just push more fluid back. It could actually make the system less active and overload it more to where it's more damaged and less helpful. So just be careful with that. Impairing circulation with excessive pressure. Of course, we don't want to apply so much pressure that we cause a pressure sore or breakdown of tissue in that area. For the application of compression, we do it very similar to other modalities. We first evaluate the patient, determine if it's safe, then we select the appropriate form of compression. We explain the procedure to the patient. We apply the compression. We remove it once it's over and assess the area, and we document. Typically, we'll apply the compression at the end of a treatment and have them go home with it. And then we would remove it and assess during the next treatment session. Or they would remove it for showering, and they may or may not be able to put it back on, depending on if they have a caregiver and things like that. And then, of course, we always document what we did. So there's various types of compression bandages. Two of the main categories are short stretch bandages, which are also called low stretch bandages. These have a high working pressure, so that means that their pressure increases with muscle contractions. So during activity, the pressure increases, improves that blood flow. The long stretch bandages or high stretch bandages have a high resting pressure, so you don't have to move to kind of stimulate the increase in the venous return or anything like that. There's increased pressure at rest, and so it's already giving enough compression at rest to increase that circulation and decrease that edema. Uniboot, this is for high working pressure, so this is typically used to treat venous stasis ulcers. It is a semi-rigid bandage formed from zinc oxide impregnated gauze, and it is used to exert pressure on the lower extremity. So they take this gauze that has zinc oxide, they wrap it evenly around the area, and then they cover that with another layer. As it dries, it hardens, and they typically leave it on for around a week or two before it's taken off and likely replaced with another. And it can help decrease significant swelling from venous insufficiency and help with venous stasis ulcers. All right. Multi-layer compression bandage system. So sometimes we will use various, and I just realized A is at the bottom, C is at the top. Sorry, I didn't switch that. But various types of bandages with different elasticities so that, I'm sorry, it applies pressure both at rest and while working. So when they're resting, there is just a constant amount of pressure applied, but when they're moving, there is more pressure applied to decrease that edema. I'm choked. Compression garments typically are used for lymphedema. They can also be used for burns, for residual limbs, and other things. They have various degrees of compression and various sizes. So sometimes you'll start out with a larger one or maybe even less compression. And as the edema starts going out, you may have to incrementally decrease the size, like the circumference of the pressure garment, or you may have to get one that has more pressure or compression over time to continue to improve their symptoms. And they are, like what we said before, typically worn about 23 hours a day and only removed for showering. Oftentimes, too, we do have them remove them when they get to PT, if they're doing PT, before their exercises, because you do not want them sweating in the pressure garments. You don't want them to be wet because it could cause skin breakdown, but also if they sweat in them and need to wash them more, then that's less time that they're wearing them unless they have, two compression garments that they can alternate between. But most of the time we have them take them off for their exercises and put them on at the end of their therapy session. This is a Velcro closure compression device. It's inelastic, it's adjustable, and it can apply compression in various areas. It's pretty easy to put on. That's one of the issues with wrapping a patient's leg. Let's say you wrap it, they go home, they can't shower without taking it off. And so just depending on how often you're seeing them, they usually cannot rewrap it themselves. And maybe they have a caregiver that could, but if it's not an even amount of pressure applied to the area, then it can create blood pooling. It can create pressure sores. There's a lot that can go wrong if compression is done wrong. So something like this gives the patient the freedom to wrap it themselves and take it off when they need to. But it typically is not quite as encompassing, not as therapeutic, but it would be, a good option. Intermittent pneumatic compression. We saw one example of that earlier. Here's an example that you'll see in hospitals quite often. They are pumps that provide force for compression. You typically attach them to a chamber sleeve through a hose. So like in a hospital bed, typically there's a hose that you attach it to at the bottom and you put them on and they just inflate and deflate to squeeze and release the pressure in the calves in order to kind of fake that muscle pump and push the circulation back towards the heart. So a lot of times after surgeries or somebody who is on bed rest or something, this is really important to have them on basically anytime they're in the bed in order to keep them from getting a blood clot or a deep vein thrombosis. And if you notice in the picture, the person also has on compression stockings, which is pretty common. They'll wear compression stockings and the pneumatic compression device. So if your goal is to reduce edema or prevent a DVT or reduce a venous stasis ulcer, the parameters that are recommended are a 3-to-1 ratio. So typically you would have them inflate for 80 to 100 seconds and then deflate for 25 to 50. Versus with residual limb reduction, it's a 4-to-1 ratio. So typically you would have it inflate for 40 seconds to a minute and deflate for 10 to 15 seconds. Otherwise, the parameters are pretty much the same. For the arms, you want 30 to 60 millimeters of mercury for the pressure. For the legs, it's typically 40 to 80. And then both of the devices ideally would be worn for around 2 to 3 hours at a time. All right, for our documentation, this is just like many of our other modalities. We want to, of course, document what type of compression, what area of the body, the patient's position. For this one specifically, you also want to document inflation and deflation times, compression and inflation or inflation pressure, treatment duration, and then the patient's response to the intervention. So that is it for compression for today. So I will see you in the next lecture.